glad we don't have elections every year. Just wait for the last stragglers to take their seats, please. I'll hand back to the chair.
Thank you. So our next topic, environmental sustainability in healthcare. The draft motion that, noting its current position statement on climate change and human health, our AMA supports further investigation into environmental sustainability measures that could be incorporated into healthcare across Australia. Moved by Dr. Kennedy, seconded Brad Frankham. Tessa, are you ready? Thank you.
Thank you, Chair. And now for something completely different. So when we talk about sustainability in health, we're usually talking about spending and about workforce. But what about the physical environment? We know that our existing AMA policy acknowledges that human health is ultimately dependent on the health of the planet and its ecosystem, and that climate policies can have a public health benefit beyond their intended impact on the climate. These health benefits should be promoted as a public health opportunity, with significant potential to offset some costs associated with addressing climate change. Yet the health sector itself contributes about 7% of all greenhouse gas emissions and an enormous amount of plastic and other wastes which take a direct toll on patient health and the health of our environment, as well as the way we run our hospitals, becoming increasingly unsustainable from an environmental perspective. Health facilities and health workers should promote a holistic approach to health, including its social and its environmental determinants. Now, I think we've started to do this in some great ways. Many hospitals, well, I think it's across the country, but certainly in New South Wales, every hospital is a non-smoking area because tobacco is a significant risk to health. There have been efforts to improve food options available in hospitals and reducing the sugar content, particularly in beverages, because obesity is a significant risk to health. Yet every time I place a cannula, suture in a chest drain, resuscitate a baby, I generate a large amount of disposable, non-biodegradable waste, including plastics and instruments that have barely touched a patient before they touch the sharps bin. When I wash my hands tens of times a day, paper towels are commingled with non-recyclable rubbish simply because of the lack of availability of recycling bins near a sink. Many of us will drive to work because of lack of public transport options, particularly when we're working shifts, and lack of showering and changing facilities required to encourage active self-transport options. Disposable coffee cups, volatile anaesthetic gases, computers and lights left on overnight. There are many wasteful practices which would actually take quite little effort to change. So I think we have a really great opportunity to improve our practices with associated measurable improvements in patient outcomes and cost savings which can be reinvested into the health system, such as those demonstrated by the UK NHS Sustainable Development Unit. This dedicated unit has coordinated research, policy and action to improve the sustainability of healthcare. They've succeeded in cutting NHS greenhouse gas emissions by 11% in the 10 years 2007 to 2017, despite an 18% increase in health service activity. To quote Associate Professor Forbes McGain of the University of Sydney and Doctors for the Environment Australia, the healthcare system can't become low carbon and low waste without leadership, incentives and direction. And I believe the AMA is best placed to do this. If we're sincere in acknowledging climate change and environmental degradation as one of the most significant threats to human health in our time, we must acknowledge too our part in addressing it in how we work. Environmental sustainability in healthcare needs a triage category upgrade, and we must respond. I commend this motion to you.
Thank you. Speakers to the motion, microphone 1, against, microphone 2. Microphone 1.
I'd just like to support the motion briefly. There is a lot of interest in, Ross Kerridge, anaesthetist from Newcastle. There's a lot of interest in this in the anaesthetic world. About 25% of the carbon output from hospitals comes from operating theatres, and there's a whole lot of things in our clinical practices that are environmentally damaging and could be changed with no risk to the patient at very little cost and are really just a matter of rethinking packaging and disposal of waste. In fact, disposal of waste is one of the easiest things to fix. Reduces cost to the hospital very rapidly from the cost of waste disposal. So it's a really good motion, and I'd endorse it strongly. Thank you.
Thank you. Microphone 2.
Mark Yates is any brave person who ever stands to say we don't want to be environmentally sustainable, but that's not what I'm saying. I guess the reason I oppose this motion, and I'm sure it'll get passed, is because I think that this is an opportunity for collaboration and not something that the AMA has to do itself. We do have to acknowledge that within our own organisation we have a limited budget and we've got incredible expertise in some areas, but perhaps not brilliant expertise in others. The College of Physicians has a huge portfolio of interest in environmental and other sustainability, and I would just put it to the membership here that in fact this might be best, the motion might best direct us to collaborate with our co-colleges rather than actually investigate for ourselves. So it's not really opposition, but I'm just imploring us to perhaps not actually do everything for ourselves, which is very costly, but go into collaboration.
Thank you. Microphone 1.
Michael Gannon, I'd like to support the motion. The reality is that doctors need to show leadership on this. We are in a position where we can make changes. There are too many changes in hospitals that get foisted upon us, and we need to push back against those. So much of the use of single-use items is not based on evidence. It's usually because of a 1 cent saving here or there, and many times it's in areas where there's no risk of transmission of blood-borne viruses, etc. We will face disruption in the next generation, lots of traditional jobs going. There are opportunities for more jobs in hospitals for low-skilled workers in going back to cleaning multiple-use items and things like that. We need to lead. This is real environmental health in action.
Thank you. Microphone 1.
Yeah, Brad Franken. Very briefly, I support the motion. I support what people have just said. It doesn't just need to be hospitals, though, can I point out. We're talking about energy, waste, water, facility design, procurement and transport. That applies to private practices as well. And the good thing is that if you do this well, you actually save money. It doesn't cost you money. Thank you.
All right, thank you. Tessa, anything last words to say?
Just a very short response, I suppose, to I think it was very commendable to speak against it if you have something to say. In the other sessions we saw some people vote against without explanation, and I think it's really important to have that balanced debate if difference in opinion exists. I do actually agree with the sentiment that there are lots of priorities that the AMA has, and that's why I suppose I ended my initial comments with saying I think this just needs a triage category upgrade. I think for too long we've perhaps relied on, again, quite broad statements saying climate change is bad, stuff should happen. But I think that we have a great responsibility, as Dr. Gannon has pointed out, to actually lead that change. And even if we don't come up, I'm not suggesting we generate the evidence ourselves, but certainly that we do work with those who are best informed to then get the message out there, highlight the importance of it, and bring that to our hospitals and our healthcare facilities, wherever it is that we work.
Thank you. All right, we're ready to put the motion. Can everybody wake up their devices? Just press any button. The motion is open for voting. The motion is carried. Thank you. We'll now go to the topic AMA schedule of recommended fees. And can I ask Doctors Pesha, Cox and Dupelia come down so they're waiting their turn. So the motion is that our AMA fund the development and maintenance of a reworked AMA schedule of fees with ongoing indexation firmly embedded in it that is transparent, meaningful and defensible, and consider wide distribution to government, insurers, providers and the public of the reworked AMA schedule of fees so it can form the basis for public awareness of doctors' fees. Moved by Dr. Gino Pecoraro, seconded Associate Professor Julian Raitt. Thank you, Gino.
Thank you very much. We're at a stage in the health cycle where we've finally got government looking at the funding of our health service. How this is happening is because they're looking at both the insurers that are responsible for paying for healthcare in Australia. We've got the federally mandated Medicare rebates, and then we've got the private health insurance rebates. For the first time, they're actually starting to look at Medicare rebates. Traditionally, they haven't been indexed to anything at all. In fact, in pathology and radiology, not since its conception. For other services, every now and then they pick something out of the air and try to index it to try to make people feel as though they're getting some value. For poor general practice, what they'll do is throw a bribe and call it an incentive payment of some description every now and then to maintain bulk billing rates. I think the time has come where government would actually listen to us, and in fact we're going to ram it home so they can't help but listen to us. We want a method of indexation, whatever it is. A method of indexation needs to happen, and it needs to be embedded in legislation so it's not at the whim of successive governments. I believe the best form of indexation of fees, of any fee structure currently available, is our fee structure, the AMA fee structure. It's the only one that has been indexed since it started, the only one. I think that this is such an important thing that it will require funding, which will have to be okayed by the board. So I want this meeting to tell the council, you do need to talk about it. The absolute words aren't that important, but it needs to be on the agenda for the Federal Council so that we can find a way that we can all live with so that we can index it. Then we need to widely promote it. And I think we need to certainly get it out there more than just to our members because it gets leaked anyway. We know that if you read papers from previously, the association is making money from selling these fee structures to various other groups. So if we're going to do it, why not turn it into something that could make us money, but that can then form the basis for further discussions on fee rebates. I commend this to you. It'll help not just GPs, not just private doctors, but also the public hospital, because if we can finally fund general practice appropriately so that they can spend the time they need and do real preventative healthcare, it'll decrease emergency admissions. It is good for everyone. The time has come. I commend it to you.
Thank you. We'll ask speakers for the motion, microphone 1, against the motion, microphone 2. Okay, all right, microphone 1, thank you.
Mark Orchard, WA. I'm going to be voting for the motion, but I would like to say that the AMA fee has been indexed appropriately for ages, so that's the first part of the motion doesn't really change anything. So really it's about, do we promulgate our fee schedule or do we keep it for our members? And we know that it has been one of the value propositions, so we do need to be quite careful about removing another part of our value for members and giving it to everybody in the profession without retaining it just for the members. But my main point, I think, is that our system is not ready for the future. And we can redo our schedule, that's nice, we've got MBS reviews, we can only do what is achievable. Talking about the AMA fee will not make it the standard fee. It will not make it the standard fee in general practice. It will not make it the standard fee in the private sector because it can't be afforded by the system. It would be an enormous increase in expenditure. So in my view, what the AMA should be doing is putting our effort into long-term reform. We need to improve our capability at understanding health economics, and we need to be talking to everybody over a period of 10 years about what real reform in healthcare looks like, keeping the good things about our fee-for-service system, but also realising that there's lots of gaps and that this dual-funded, partly activity-based, partly not system isn't working for anybody and certainly isn't preparing us for the future.
Thank you. Microphone 1.
Yes, thanks, Chair. Mark Sinclair, an anaesthetist from Adelaide in private practice, and I'm a member of the AMA's Council of Private Specialist Practice. But for many years prior to that, I've been in the Australian Society of Anaesthetists spokesperson on these sort of issues, and I just wanted to support Gino's one specific aspect of his motion, which is that we need to get information about indexation out there. The 30-odd years of poor indexation of the Medicare system, the 7-year freeze we're going through now, it's not a 4-year freeze, it's a 7-year freeze since 2012. And when I talk to insurers and health department bureaucrats, they really feel quite uncomfortable with this idea of publicising indexation and lack to patients, because then they can't blame us for it, for the out-of-pockets. So I support this motion strongly.
Thank you. We'll go to microphone 2.
Hi, Danielle McMullen, GP in New South Wales. I may be at the wrong microphone. I don't disagree with the draft motion, but must speak out against a couple of items in the preamble to it. The first thing is that I take offence to the sentence about younger or junior doctors not being interested in running a business. I think that's offensive to a lot of our junior doctors here who are interested in running a business and taking on those challenges. I also think that while fee-for-service remains an important part of our medical system, and I strongly support doctors being able to charge what they feel they're worth, we need to remain open to novel models of care and funding and novel models of workflow. So we should be able to balance our right to charge what we're worth with providing affordable, accessible care to our patients.
Thank you. We'll stay with microphone 2.
So I also, using the precedent, I didn't want to walk across there. I don't oppose the motion, but I would like to highlight something which I think needs to be considered with this motion, which I do support. And that is, if we are going to be talking about a conversation about a new schedule of fees, and I agree there needs to be an agreement on indexation, we need to open the conversation at what point, if we expect insurers or the other payers to pay more, which we're going to ask for, will we then trade off the fact, if you do give us this, then we believe that doctors should not charge above that. Now, I know that goes against the visceral thinking and feeling of a lot of people in the organisation, that they should be able to charge whatever they want, and they should, but if we are going to expect some extra money being put in to support a more realistic schedule, and this isn't just for general practice, although I agree, I would like to think that they would be the main beneficiaries. We, I think, have to cross the Rubicon of finally having a position on, if we do agree that it is a reasonable fee that has been established, that to access the third-party payers, whether it's government or insurers, contributing to that, that we accept that as our fee.
Thank you. Microphone 1.
Mark Kinguri from Perth, Federal Councillor and Craft Group for Radiology. First of all, indexation for radiology, as Gino's mentioned, is not 7 years, it's 22 years. So if it continues this rate, I don't think we'll have imaging altogether, because it's unsustainable at the current rate. I think for us to argue, absolutely, we need to have a very, very tightly worked economics and data behind our fees, so that they are up to scrutiny, that they stand up to everything else, and that at the end of the day does say that the real cost of providing a service is that fee. At the moment, you know, it's the MBS fee, which is nowhere near. So I strongly support this motion. I think we do need the finances from the AMA to do that piece of work and get this really totally robustly sorted out.
Thank you. Microphone 1.
Dominic Barbaro, GP Victoria. I strongly support this motion, but I would like to mention the fact that there is some inconsistency here. We've not long ago the AMA had to respond to the introduction of a gap or a payment by patients, and we opposed that, saying that the bulk billing rate will be reduced and all sorts of things will happen to patients if they had to pay because they wouldn't go and get to the treatment that they require. So in supporting this motion, I would like to add that the AMA will have to actually take action, because this by itself is not going to push the government to do what we request. It has to be supported and also activated by action such as encouraging our members, the profession, not to bulk bill. The government will have to be pushed in some way to have some of this implemented, and then we negotiate. But this by itself will remain as it is, and it has been for many years. They'll freeze, unfreeze rebates, but the real action is when the government doesn't really play ball.
Thank you. Microphone 1.
Thank you, Karen Phelps, New South Wales GP. I have been around long enough to remember the relative value study and its many challenges and iterations. And there's no question that the RVS was well intended, but it didn't have the outcome that we would have liked to have seen. And in particular, what has come out of any review of the Medicare benefit schedule has been a bad deal for GPs. And unfortunately, what we're seeing in Australia now under Medicare is a freeze on a bad deal for GPs, and now we're looking at the possibility of indexation of a bad deal for GPs. And this rebate freeze that has been imposed on us, and GPs have been basically taking up the slack for the funding of the healthcare system for a really long time. And one of the things that I've noticed about the debate today, and I think that we have to caution against this, is thinking about the Medicare rebate as the payment for the doctor. It's not. It never has been, and we should fight against it ever being the payment for the doctor. It is an insurance safety net for patients. Doctors need to be able to charge according to our professional worth, regardless of what the Medicare benefit schedule says. If we can align our worth with the Medicare schedule, then we are going some of the way to achieving what we need to achieve. The AMA setting a schedule of fees is an important step. I think it's a statement by the profession, led by the AMA, but it also needs to be said in parallel that the Medicare benefit schedule and the rebate is not a reasonable fee, particularly for general practice.
Thank you. Gino, a minute.
Thank you very much. I agree with what everybody said. I never expected this to be the payment that GPs or anybody else got. I think there's heaps of work that we need to do. Don't let any of the details put you off voting yes. We need this to get onto the Federal Council agenda so that we can work to find ways to make it transparent and defensible. There's a lot of work that needs to be done, but we want to send the clear message to Council that the board has to fund this. Thank you. Vote yes.
Thank you. Well, the motion is ready for voting. And voting is open. Thank you. Yep. Not. Oh, and the motion is carried. Thank you. So the next topic is, and now we're on wood, we've got 32 minutes and 3 topics, and I'm grateful to Brad Frankham, who threw his colleagues under a bus and withdrew several motions, so thank you, Brad. So the topic is the implications of the Dr. Haditha Bawa Garba case for Australian doctors. The draft motion, do you want me to read that out? It's a lengthy one. That our AMA notes the case of Haditha Bawa Garba and its implications for doctors in Australia, particularly in light of the similar healthcare systems and stresses. that our AMA take legal advice on the implications of the case for Australian doctors and adopt a position statement that informs doctors of their protections should a similar situation arise in Australia, particularly around the use of personal learning journals. Moved by Dr. Andrew Pesha, seconded Brad Frankham. Thank you, Andrew.
Thank you. I wanted to raise this. I'm actually a bit surprised that it hasn't had a bigger profile than just this. Certainly, this was Groundhog Day for me. I remember when I heard about this case, and I'm sure you're all familiar with it. The hairs went up on the back of my neck like I did in 2001 when I got involved in all the medical indemnity stuff. Just to quickly go through it, a trainee under supervision of a consultant in a busy public hospital who had just returned from maternity leave, so all these mitigating factors, was basically thrown under a bus and convicted of manslaughter. Initially had registration suspended for 2 years and then on appeal permanently removed. And to me, this was, just about, well, at least she wasn't accused of murder. But I thought that this was something which was a great concern to myself. And I know from talking to my junior colleagues, the registrars, they were extremely horrified and scared by the implications of this. It raises so many issues. I already mentioned the trainee under supervision, the system issues which were identified in the case and discussed during the proceedings. The whole concept of, how appropriate it is and at what stage is it appropriate for the criminal justice system to be used and to intervene in what is such an obvious issue of quality and safety in a complex health system. And then finally, and especially for the trainees, the fact that it seems that one of the hanging offences, well, not the hanging offence, but the damning evidence comes from the doctor herself, who, as part of her own learning, is recording her observations and her reflections on practice, and that was used in evidence against her and quoted as one of the reasons why that doctor could never be a good doctor and would never be able to practice again. So, very, very complex. The motion is worded in a way that can be, I'm very happy for Federal Council to be creative and come up with its own wording and iterations, but I think we really do need a serious discussion. AMA, as the representative of the doctors, I think the medical indemnity insurers obviously have a lot to add here. I think we need to engage with our legal colleagues who keep assuring us that this couldn't happen in Australia because the system's all very different, but I just don't think that this is something which should be left to see if it does happen or not. And so I commend this motion and ask that Federal Council take this forward and organise a response so that Australian doctors, and especially trainees and junior doctors, doctors in training, have some feeling that we will support them and we are on their side in what is a very difficult situation.
Thank you. So,
I'll just add that New South Wales AMA did organise for a legal opinion, and possibly Brad, with your indulgence, please, you could maybe summarise that for the audience.
All right, we'll ask the speakers to go to the microphones. Those in favour of the motion, microphone 1, those against, microphone 2. And we do have the benefit of having a representative of the British Medical Association with us who knows this case intimately, so with your indulgence we might ask you for any points around that just as information after our speakers have spoken. Brad.
Thank you. So obviously I support the motion. I think the issue raised a lot of concern amongst doctors in training, but also more senior members of the profession as well. Some of the advice we received, the legal advice at New South Wales, and I quote, "Whilst we cannot say definitively that Dr. Bawagaba would not have been prosecuted and convicted of medical manslaughter in New South Wales, a review of previous cases in Australia indicates that it is less likely that the matter would be referred, or if it was referred, it is unlikely her conduct would have been found to have amounted to gross criminal negligence, as was found in Dr. Bawagaba's case." Now, I'm not sure if that's quite good enough, and that's the reason to put the motion forward to Federal Council. I also cannot state whether that would apply to other states or if it's New South Wales specific.
Thank you. Next speaker, microphone one. And
David Mounts, an emergency physician in Western Australia. I'm obviously speaking in support of the motion. I would suggest that it would be nice if our medical board was a bit more effusive on this issue. They've so far been pretty quiet and haven't sort of, really assisted the profession in working out what we do or how we deal with this case. I certainly feel very sorry for my junior colleagues working in many poor environments with very similar situations as this poor doctor would face. And we have had junior doctors thrown under the bus by public indemnifiers. It definitely happened in Queensland about a decade ago. And I just, we need more assurances, I think, than just, oh, well, it might not happen here because the legal system's a bit different.
Thank you. And I'm hoping the contributors will be brief so that we can take a comment from the representative of the BMA. Thanks, Gary.
Of course, Beth. Gary Gilhead, West Australia paediatrician, emergency physician. Look, I'd strongly support this for a number of reasons. Anyone who's read the detail there, it was like a lay down misere. So many factors are against this young woman. It also overturns the whole philosophy of the last, 10, 20 years of talking about system changes and not blaming individuals, etc., and learning from this, and that's what part of it, as you said, her reflections then helped to sort of convict her. So I certainly would support it. And lastly, I think we'd be interested to hear from our colleagues from UK, but I'm sure that it's not finished over there. This is such an egregious case, and that by us marking it here, that may have some small effect on that individual's eventual outcome as well.
Thank you.
Andrew Miller in Easterness, WA. Just 2 quick points. One, our junior doctors' lives are being ruined here through inappropriate investigation of incidents with bad outcomes. Not necessarily a manslaughter charge, I agree that's unlikely in our jurisdictions, but certainly through the administrative processes, hospital processes and AHPRA processes, there are lives being ruined already in Australia. There's plenty of cases that we can look at. The nuance for the AMA, which is my second point, is that often we have doctors on both sides of the argument and senior doctors who are blaming junior doctors, and we may have members on both sides. And the AMA needs to be sophisticated enough to have processes to deal with these kind of things, not only in the area of bad clinical outcomes, but also when it comes to bullying and sexual harassment. The AMA needs to deal with both sides of the argument, and we need to try and take the lawyers and the expense out of the entire system.
Thank you.
Hi, Rebecca Wood, DIT from Western Australia. I will keep my comments brief, but I'd like to highlight that we could probably spend the good part of a day discussing these issues, and so I thank you for bringing it to the National Conference today. When we learnt about the Bawagaba case, it struck fear into the hearts of many DITs across Western Australia, because there have been some cases where we feel that we are not supported by our seniors, and so it was very concerning for us. I'd like to highlight today that it's a very important issue that we need to discuss with our board, and specifically on the use of the reflective learning, which is required of many trainees in Australia as well, as evidence. And it really came home to me that we try to use reflective learning to accelerate our learning as trainees and as doctors in training, pre-vocational doctors as well. And true evaluation is really required to accelerate your learning. But if true evaluation is not, true self-evaluation and reflection is not protected, we won't be able to engage with our DITs when they are in training. So thank you.
Thank you. And Andrew, if you'd like to make your way over to the microphone. Next.
Thank you, Christine Thaver-Thousand. I've just got two quick comments. I think one of the main things that this case does exemplify that I would like Federal Council to consider is that this is an example of scapegoating when systematic issues arise. And the second thing which I'd like Dr. Dearden to address is my understanding was that the reflective training was used in the medical tribunal but was not used in the criminal case.
Thank you. All right, so we will invite Dr. Andrew Dearden, who's a general practitioner from Wales and a very senior figure in the BMA's council. Any information, Andrew?
Sure. Well, thank you, Chair. I'm Andrew Dearden. I'm the, the Treasurer and one of the Chief Officers of the British Medical Association. Just to put this in context, between about 2006, 2013, 11 doctors have been prosecuted under the gross negligent manslaughter clauses. Of those 11, 6 have been convicted in that 7 or 8 year period of time. The law was set by a case law in 1994, and they have to prove 4 things. One is there was a duty of care. 2 is that there was a breach. 3 is that the breach was either the cause or a significant cause towards death. And the 4th is that that breach was grossly negligent. Now, interestingly, in Scottish law, there is also a 5th one, which is intent. In other words, you have to intend it to be grossly negligent. So all of those cases are in England and Wales law. They're not in Scottish law. So that's, again, one of the confusing things is that the law varies according to country. Just for information, Dr. Bauer-Garber has been given the right to appeal, and the BMA is supporting her by, we've been given permission to intervene, which means we can now come along as an interested party and give a lot of background information that wasn't available. But just to be very clear, her reflective information, her reflective portfolio, was not used in the criminal court. Her defence has made that very clear. It wasn't made available to the court or to the jury, and neither was her supervising consultants' reflections were also not used in the court. Now, our General Medical Council, our regulatory body, has given us assurances that they would not ask for that information, but our courts do have the right to request it. So although they do that very rarely and quite unusually, and didn't in this case, they do have the right to ask for that information, and we're seeking clarification on what that means. And as you can imagine, we're committing a lot of resources to both supporting and understanding the consequences of this particular unfortunate incident. I hope that's helpful to clarify.
Thank you very much. That's very informative. All right, Andrew, any last comments?
So that's very helpful from our British colleagues, so thank you very much. And each time I hear about this, I learn a bit more. What I also do know is there's a Facebook page, there's a lot of very, very angry doctors. I know that the BMA and the GMC have taken a lot of heat, and from the AMA's point of view, it would be good if we could be on the front foot and manage this so that we don't have to react in the same way one day.
Thank you very much. So this motion is open, well, it's ready for voting, and voting is open. And the motion is carried. Our next topic, competitive neutrality. The draft motion is that our AMA considers the distortion to competition between exclusively private practice specialists and public hospital specialists with rights of private practice, and considers the diminished value proposition the AMA membership offers to exclusively private specialists as a result of AMA endorsement of public hospital rights to private practice. Moved by Dr. John Cox, seconded by Dr. John Hall. And John, thank you.
Thank you. Basically, this was a good idea at the start, and the people who decided that doctors who are full-time in the public system should have the right of private practice in their spare time was a good idea when it started, but with time it has developed into somewhat of a monster and nothing like was intended. Let me explain. About 35 years ago I went to the town I work in, it's a major regional centre of Toowoomba. I'm a paediatrician at that stage. 2 VMOs ran the paediatric ward. We didn't need full-time staff, we had 1 resident. 35 years on, we've got exactly the same hospital, the same size ward, but because of changes, we've now got between 5 to 6 full-time paediatric consultants, 8 registrars, another 5 residents. They've also got a 40-hour week. They can do in 4 10-hour days, giving them a 5th day off. So as you can imagine, there's some spare time. If I see a patient, a GP refers a patient to me, it comes with my name on the form, it comes to me, and let's assume I charge them the common fee, which is, for sake, $100. My running costs are about 50%. Most of the people in my profession, it runs between 40 to 60, depending on how much equipment you have. So I'll take home $50 that consultation. My equivalent person in the public system doing their day of private practice, the GP will refer a patient to the public hospital. They will then get a phone call or a letter saying, if you put the doctor's name on it, we will see them next week in the private practice. And it'll therefore go to the private practice and be seen by any one of the doctors, not the one whose name's on it. He therefore gets that referral easily. He will charge the schedule fee, say the $100, but his facility fee is only 15%, so he takes home $85. So for exactly the same consultation, I've had to have a personal referral to me. He's had one which has been manipulated by the hospital. He takes home $85, I take home $50, and he doesn't even have to keep his records. Now, if you're a patient in that town, where would you go? There are between 5 or 6 of them in the public hospital with a very short waiting time because the hospitals have not changed, and in paediatrics, the number of people who go to hospitals has gotten less over the last 30 years, the same ward as we had 35 years ago. And for me to generate the same amount of fee for myself, I have to charge about another $30 on top because I pay the running cost and he doesn't. It's an unfair world, and basically for someone that I represent, which is an individual specialist in a regional area, we're doomed. So if you particularly continue the system you've got, what I represent is gone. We're dinosaurs, we're dead. I suggest the AMA was in favour of this initially, and it is nothing like what they set out to be. So I recommend that this be pushed forward to Federal AMA for them to consider the distortion that exists and consider the diminished value that AMA membership has, because you all know that what I represent, the individual, quite a number of those numbers are in the AMA, whereas those in the public hospital, the AMA membership in our area is extremely small. Thank you.
Thank you, John. Those who are speaking in favour of the motion, microphone 1. Those against, microphone 2. Thank you.
Thanks for that, John. My name's John Hall. I'm a GP obstetrician from Toowoomba in Queensland. I'm also the chair of the Rural, Regional and Remote Subcommittee of the Queensland Branch Council, and I'm a past president of the Rural Doctors Association of Queensland. I support the premise that universal bulk billing or bulk billing of specialist outpatient services in our public hospitals is bad for the health system. I want to commend to the audience an article by Dr. Tim Leuenberg from Kangaroo Island, who's one of the moderators of GPs Down Under, which is a 5,300 member strong forum that has heavily debated this topic. He's written an article which is currently published in the MJA Insight on the 21st of May 18. There is links to that article on the Twitter feed, and if you Google Tim Leuenberg and Medicare, it'll come up second. So I commend that article to you, and I'm going to give you some of his main points which supports John's argument. Basically, the point is that it is skewing Medicare bulk billing rates, which is affecting government policy with respect to bulk billing across the board. It is creating barriers for access for our patients into public outpatients, and the story that John gave about referrals being bounced back from outpatients asking for name referrals often creates a barrier. Patients often fall off the waiting list in that context, or their appointments are delayed. And we believe that there are some elements of potential Medicare fraud if the patients aren't actually seeing the person on the named referral and they're seeing a registrar in that clinic and they're not actually seeing the specialist. There's potential gaming and illegal activity when it comes to Medicare and specialist outpatients in public hospitals. Also, I would also agree with John's premise that this is limiting recruitment of private specialists into regional areas. A survey that the Rural, Regional and Remote Committee did in Queensland, the key concern of that came back from that survey was that our regional and remote doctors were concerned about the range and the number of specialists in regional areas. And as rural doctors, we need strong regional hospitals, and we need a broad range of supportive specialists to practice our craft. So in summary, I think one of the best ways to put a blowtorch to the Medicare freeze would be to stop this double dipping and look at better funding hospitals directly and making sure that the MBS is reserved for supporting primary care in a situation where it's currently underfunded. Thank you.
Thank you. Microphone 2.
Thank you. Jeff Dobb, public hospital doctor from WA. I could probably speak for 20 minutes on this particular issue, but I'll confine myself to a couple of points.
Thank you, Jeff.
And they are that the right of private practice is an integral part of the salary system for public hospital doctors in Australia. Depending on where you're working, it contributes about 25% of income. So in relation to the second part of the motion, it wouldn't just reduce the value proposition of AMA membership, but it is unlikely that salaried doctors would be able to afford their AMA membership any longer. So certainly a major problem with this motion there. The other issue relates to services in country areas. Now, while you can find a cardiologist in just about every country town in WA, you won't find a nephrologist other than the public hospital nephrologists who do clinics in country WA. And if we didn't have that service, then there would be a complete failure. And the last point relates to general practice. There are, particularly in country towns, there are many practitioners or areas that have a Section 19B exemption that allows doctors working in the local small hospitals to bill the MBS for services at those public hospitals.
Thank you. Microphone 1.
My name is Dr. Sriram Nath. I'm a hematologist in private practice, and I support this motion. Basically, being a solo practitioner, I have to fork out all the fees for rent, electricity in my practice. And when patients come to me and say that, can you charge Medicare rates? My first question is, if someone is going to give me free electricity and free room to see the patient, I'm happy to charge Medicare rates. Unfortunately, it's not a level playing field currently. And what I find is like the government system, of course, the state governments are cost shifting, trying to get the patients in the eastern seaboard sort of model where consultants see the patients in their rooms and then get the patients into hospitals. So the question comes down is, as pediatricians, I can understand there's no pediatric private hospital in South Australia where patients can be seen in a private setting. So we have to keep that also in mind before saying no to this motion. So the question comes down is like, if we are going to have a private system which is dependent on patient, gaps and Medicare rates and private insurance for inpatient billing, the government system has got, has got funding, say from the state government, from Medicare and private insurance. I rest my case.
Thank you. And we'll go to microphone 2. I'm hoping it's a minute each for you gentlemen. I don't want to lop our last topic off the agenda.
Happy to be kept to calm, Chair. Mark Adds, geriatrician based in Ballarat Regional Centre. Without rights of private practice, I relinquished them and got a 20% addition to my meagre full-time salary. Look, I understand the issue here, but there's two things that I think I'm absolutely stunned by. First of all, here we are having a debate that says that there's specialists who actually believe that the MBS is what their payment is. I heard a whole lot of specialists a moment ago saying how we've got to stop this and the GPs are really being irresponsible about just bulk billing everybody. So that's the first problem I have with this debate. So the second problem is that really is this an issue of changing and lack of level playing field? We all understand that the MBS by specialists in public hospitals is all about cost shifting from the feds from the states to the feds, and that's always what it will be. But that's not the debate that's being put forward here. We've got to work together as a group, and all we're going to do is eat each other alive. And there aren't enough specialists in regional centres already, so let's try and keep them.
Thank you. Microphone 2.
I'll just pull that down. Omar Korsha, WA, mainly in private practice, a little bit of public work. I think we've forgotten the patient here. The right of private practice in a public hospital provides access to the right specialist for the right patient in the right hospital for a lot of our patients. And removing that, I think, would be a really retrograde step. What we heard about really is cost shifting, and we have already policy against cost shifting, and if we want to get rid of cost shifting, let's look at that. Let's not look at things that harm our patients, because at the end of the day, that's what we're supposed to be here for. The last thing I wanted to say is you know, private practice is a commercial world. It's based on competition, and if you can't compete with your private hospital, your public hospital in terms of the service you provide, then perhaps you need to be thinking about that, because at the end of the day, the service I provide in my private practice is very different to the service that the patient gets in a public hospital, and that value proposition is one that means that they'll pay my fees.
Thank you. Last speaker, microphone 2.
Thank you, Madam Chair. Tony Sara, I'm an AMA New South Wales Council. I do have a professional conflict of interest in that I'm the President of the State Union in New South Wales, ASMOF, and the Vice President of Federal ASMOF. I think we need to be very careful about undoing rights of private practice. They were developed many years ago to prevent public hospital specialists going to the private sector. The reason for that is that our teaching hospitals are the crucible of the profession of medicine. There is very little training for most of the hospital-based specialties in anything other than public teaching hospitals. And therefore, if specialists are encouraged to leave the public teaching hospitals, what does that do to us as a profession in the 5, 10, 15, 20-year history? I think, therefore, to undo rights of private practice has a significant danger to us as a profession and our future maintenance. Therefore, I would be arguing against this motion. Thank you.
All right, now, Dr. Rudd crept up on me there, so can you do it in 30 seconds?
Sorry, I just wanted to hear what our comrade Tony would say before I spoke. I think that this is asking Federal Council to consider something, to have a look at this. It's not saying get rid of the right of private practice in a hospital. It's not saying that at all. There's no problem with the right of private practice in a hospital, as long as that's what you're actually doing. Having outpatient clinics which are all private, in inverted commas, in a public hospital is not really the right of private practice. It's skew-whiffed, and I think it's reasonable that we consider it. We're not suggesting to get rid of the right of private practice. It doesn't say that anywhere in that motion. Thank you.
Thank you. All right. Now, John, do you need to say anything else? Because I'd like to put the vote.
You can talk as much as you want, but this is reality. And sometimes in your life you have to pay reality, and the reality is at the public hospital, my equivalent is getting preferential referral systems taken from the public system with a name change and taking home 1.5 times as much money for the same visit as I achieve. If you want to keep supporting it, there will be no independent specialist in rural areas. It's up to you. Thank you.
Thank you. And we'll now put that vote. And voting is open. Thank you, Dylan. Split vote. Doing well, Bev. Doing well. Yeah, we're nearly there. We'll just be a couple of minutes over. And the motion is carried. Our last policy topic, the modified Monash model classification for all government programs. The draft motion that our AMA calls on the Commonwealth Government to adopt, subject to appropriate transitional arrangements, the modified Monash model of classification for all its workforce and funding programs, except where it can be demonstrated that the modified Monash model is inconsistent with the policy objectives of the program. Moved by Dr. Dilip Jupilia, seconded Peter Maguire. Thank you, Dilip.
Thank you, and thanks for keeping the best policy debate to last, which is the rural one. I'm Dilip, and I'm AMA State President in Queensland, and also representing the AMA Council of Rural Doctors. So this is all about the geographic classification system that the federal government uses for its workforce and funding models for the rural area. Using the geographical classification systems for health purposes has become increasingly important in describing the distribution of health workforce and the population. But the problem is that even though the department started developing geographic systems for use in policy development way back in mid-1990s, we've now got several iterations and several systems that have come in since then. Currently, the Commonwealth Department uses the following classification systems. It uses the Rural and Remote Metropolitan Area, which is RAMA, the Australian Standard Geographical Classification Remoteness Area, ASGC-RA, the Australian Statistical Geography Standard Remoteness Area, ASGS-RA, Accessibility Remoteness Index of Australia, ARIA, the Pharmacy Access and Remoteness Index of Australia, PHARIA, and most recently the modified Monash model, or the MMM. So hope my urban colleagues are as confused as we get in rural areas. We know there's a number of challenges using multiple geographical classification systems. For example, the RAMA is based on 1991 statistical local area boundaries and 1991 population census data. It's outdated. It does not reflect the significant population changes and urban expansion that has taken place since 1991. The ASGC-RA system was used after 2010 to guide the distribution of rural GP workforce incentives, but it proved inadequate for the task. In particular, the smaller rural communities often found themselves competing, and they were competing themselves with larger centers that were in the same classification band to attract and retain health practitioners. ARIA measures geographic accessibility and does not provide a definition for rural Australia, which is needed to provide a more complex measure that incorporates socioeconomic and demographic aspects of remoteness. The latest one, the modified Monash model, has many advantages, including it incorporates statistical measurements linked to health service data as opposed to be merely a blunt geographic tool. It represents a more evidence-based approach to determining the best classification system. It addresses disadvantage in small towns and localities under the current RA that are experienced under the current RA classification system. And it provides the ability to link higher incentives to smaller locations with demonstrably greater health needs. The modified Monash model was developed by eminent rural academics at Monash University and was modified following consultation with key stakeholders. It is a consistent and well understood system supported by the best available evidence. It uses two key indicators for classification of rurality, that being the ABS measure of remoteness, which is based on the population census data from 2011, and the local town size. The rationale for doing so is that these two indicators provide a proxy for measuring the relative differences in lifestyle and work conditions for health practitioners, particularly GPs. While we recognize there is no perfect system to measure rurality and that anomalies will occur regardless of what model is implemented, we believe that M classification system better differentiates between locations under which the classification systems would be considered equivalent, but which have very different challenges. In the federal budget, we saw the government update the geographical eligibility criteria for medical benefit schedule bulk billing incentive item 10991, adopting the MMM from 1st July 2019. This will replace the current RAMA classification system. Despite this, the majority of Commonwealth government programs remain operating under other classification systems that are generally seen to be inferior to the M. The AMA has strongly supported M as being the most appropriate measure of rurality, and therefore we believe, provided that the MMM is consistent with the purposes and intent of the design of these programs and appropriate transition arrangements are in place, there appears to be no reason why it should not be extended to the majority of the Commonwealth's programs. In this context, the modified Monash model of classification should be adopted for all workforce and funding programs, except where it can be demonstrated that the M is inconsistent with the policy objective of a program. Thank you.
Thank you, Dylan. The speakers, those in favour to microphone 1, those against microphone 2.
I'd like to speak in favour of it because that was a really interesting lecture and I've learnt a lot from Dr. Japilia, and it would be ungracious not to support his motion.
Yeah. Thank you. We are looking for some grace and favour at this time of the day. Microphone 1.
John Hall from Queensland again. I strongly support the motion. The AMA and the RDAA have got an agreement with the Rural Rescue Package, and it hinges on this classification. The current rural training infrastructure grants by the Commonwealth are using the old one, the ASGC. Many of us have had grants knocked back in places that genuinely need upgrades with respect to teaching and infrastructure. So I strongly support the motion. Thanks for putting it, Dilip.
Thank you. Microphone 2.
Stuart Day, immediate past President of Tasmania. I'm against the motion, but I'm for one consistent, logical, clinical appropriate classification system. The MMM system really doesn't deliver in my view. Tasmania is largely rural and regional, and it is a good practical example. Hobart, MMM2, 200k plus population, every specialty you can think of, including cardiac surgery and neurosurgery. Launceston, MMM2, same. A non-accredited emergency department because it can't attract emergency doctors, can't attract anaesthetists even though they're in oversupply. Our specialist GPs are our endocrinologists, our persistent pain specialists, our rheumatologists, and I could go on. Burnie, just one further down, MMM3, 30k population, largely staffed by international medical graduates. I don't believe that the MMM differential between Hobart, really a capital city, and Burnie delivers on what we are asking for. We need a more nuanced system than we've currently got. It doesn't deliver for workforce or funding. Thank you.
Thank you. Last speaker. Oh, sorry, yes. Microphone 2.
My name is Dr. Nathan Abraham. I'm President of the Doctors in Training Subdivision at AMA Victoria. I'm also a Monash University graduate, funnily enough. I'm not standing in opposition to the motion per se, I just wanted to ask some clarification of the motion's authors. Just with regards to the intention of the motion, is it to completely supplant all other classification systems? And the context I bring is I myself am a bonded medical graduate, and there are a number of people in this room that are, and AMA Federal has made some massive gains in the most recent budget with regards to that program. Very good work from Warwick and the team at CDT. My concern being that I signed a contract in year 12 with the RA classification being the primary rural classification model that was used. And they've subsequently updated the contracts to include the modified Monash model, but have had RA classifications grandfathered in with the understanding that we did sign those contracts with that classification as in year 12. And we wouldn't necessarily lose out by having a newer classification model brought in after the fact. So that's my only concern. I just wanted to ask for clarification what the intention of the motion was.
Okay, thank you. We'll complete our speakers, so thank you.
Peter Maguire, GP from WA and seconder of the motion and member of the Council of Rural Docs. In brief, we thought about this quite hard. We realised there may be problems. We think the modified Monash is the best geographical classification we've got. It's not perfect. There is no perfect solution. I acknowledge the problems of Tasmania. But we felt that we have to work towards a single classification system. The motion does mention transitional arrangements and also has a safety clause that where a particular issue arises, maybe it's the bonded students, that there's a facility to have special arrangements in certain cases. So overall, we would strongly commend that we have to work towards a single system.
Thank you. Dilip, 30 seconds. I think we'll take the particular question about bonding offline. So.
My understanding of the contracts is that you've got to actually, if you've signed the contract and you agree to the change, then you'll actually sign the new contract. So you actually have to agree to the stage. This is not meant to be, this motion is not meant to be where it actually causes any disadvantage. Is it where we need a transition model to move to a modified Monash model, then we should actually push for that. We can't have antiquated geographical systems because federal government will actually fund policies against those systems. We need to move away from the 7 or 8 systems that we've got into one system with a safety net of a transition where it actually seems to be causing any disadvantage, including Tasmania. Thanks.
Thanks very much. This motion is now ready for voting. Thank you. When you're finished voting, can the people who have moved urgency motions come down so they're waiting in the front row of chairs, please? And the motion is carried. Well, that concludes the maiden voyage of the AMA's Democracy in Action National Conference program. Can I thank all those who submitted motions, and can I particularly thank those who withdrew motions from today's program. I want to thank the Secretariat for their assistance in preparing today's agenda, but most of all I want to thank the delegates and members here. It's been a remarkable day in my view in terms of the number and the quality, the thoughtful contributions that we've heard here today, and we would be grateful for your feedback, you know, casually, formally, so that we know whether or not you'd like to see this again in another program. So thank you. We'll close that session and we'll move now to the urgency motions which we accepted yesterday. Now the rules for the urgency motion debates are 3 minutes for the mover of the motion and a 1 minute right of reply at the end of other speakers, 1 minute per speaker, and this will be policed. This is a traditional part of the meeting, so the rules are very well known, and we require a simple majority for the motions to be passed. So the first motion is Dr. Paul Bauert, come to the podium. Paul, I'll get you to read your motion, and it's seconded by Dr. Sean Rudd.
Thank you, Paul Bauert. I'm a paediatrician from the Northern Territory, and the reason I'm up here is because I have been the Vice President of the Australian Paediatric Society, and they've asked me to speak at this meeting. And the motion is that National Conference request Federal Council to advise the Federal Minister for Health that the Australian Medical Association insists it is the treating doctor's primary role and responsibility, in collaboration with and with informed consent of the parent, in training school staff to administer the prescribed medical treatment, including insulin and glucagon, and manage complex medical care for their child with type 1 diabetes on their behalf. The content of the training is individual to the child with type 1 diabetes and solely the responsibility of the medical team and parent. So this motion basically relates to the preservation of the doctor-patient relationship, and it also supports doctors who are bound to take responsibility for their prescribed treatments. And the issue relates to the administration of insulin, a Schedule 4 drug, to a child at school on behalf of the prescribed doctor and consenting parent. In the absence of a school nurse, which is excuse me, the situation in most schools in Australia, thankfully not in the Territory, but most schools in Australia, it's the nurse who are authorised by law to administer such drugs. But if there are no nurses, we rely on school staff who volunteer and then being adequately trained by the parent and the school and the child's medical team. Each individual child should have individualised treatment pertaining to their particular circumstances, treatment regimens, etc. This is the responsibility of the child's doctor and the treating medical team, and doctors have obligations to provide informed consent. The reason we've ended up in this situation is fairly grotty, but it relates to Minister Ley in early 2017 wanting to address the situation that children weren't getting any insulin at school, and it was difficult to get glucagon, in fact. And she asked for submissions to sort this out. And submissions came from around the country, generally agreed to initially by all participating people, including Diabetes Australia and APEG and the International Society for Paediatric and Adolescent Diabetes. Somewhere along the line, Diabetes Australia managed to change things so that instead of the requested funding to allow adequate...
15 seconds, Paul.
15. God. So instead of the adequate instead of funding going to the following the child, Diabetes Australia accepted the several $1 million involved and undertook to do the training, which is a remit they have absolutely no authority for. This is all, it's not about the nitty-gritty of that process, it's about trying to maintain the doctor-patient relationship and to stop third parties who aren't trained for such a role interfering with that relationship.
Thank you. Speakers for and against the motion? Those in favour can go to 1, those against to 2.
No, Dr. Rudd's coming.
Yep.
Sorry, it looks like a slam dunk, but I better say something saying I seconded it. I think very simply this is about task substitution rather than task delegation. It's about creeping scope of practice, and it's just one of the first steps along the way to manage care. Thank you.
Thank you. Microphone 1.
It just seems to be a good idea, an idea of a good policy that's gone wrong, and I totally agree with Dr. Bowd that it interferes with the doctor-patient relationship, so it's obviously gone wrong in a bad way.
Right, thank you. Now, we're back to old-fashioned methods now. Do you all have voting cards? And if you don't, we're going to have to just put hands up. All right. Those in favour of the motion? Oh, yes. Thank you. Hands down. Those against? 1, 2, 3, 4. 4. And abstentions? 1, 2, 3, 4. Okay, well the motion is carried, meets the guideline of a simple majority. Thank you. The second urgency motion, Dr. Mark Yates coming to the... That Federal Council as the most appropriate body be requested to look into advocating that AHPRA reduce the hours required to maintain general registration when limited to teaching and or academic activity from 152 to 45 hours per year. Moved Dr. Mark Yates, seconded Dr. Christine Thavastan.
Thank you, Chair. Thank you also to the National Conference for accepting this urgency motion. And I'm also quite conscious that this motion really is advisory to the Federal Council, and so if there are nuances, it could be refined. However, I need teachers in my regional centre, and I don't want to lose the wisdom I have in those centres, and I'm about to do that for 2 practitioners. I don't think anybody would argue that bedside teaching or clinical reasoning are 2 things that get lost over time. Recency of practice might be important, but when it comes to the fundamentals of getting by the bedside, the concept that you must maintain 152 hours of teaching in order to actually continue that is ludicrous. And why has this happened? Well, this has happened because I think the board, as usual, in its usual way, hasn't really thought through the issue. Ask those who are over 70 and wish to have cognitive screening tests. But if you Google agreements to restricted practice, you'll find the actual application to apply for general registration with a restriction that is for teaching and academic purposes but no clinical care. And if you complete that, you will see that there's a requirement not only for your 50-hour CPD per year, which is not unreasonable, but also for a recency of practice, which was modified on the 29th of September 2016, so that if anybody with a general registration, limited or otherwise, has to maintain 152 hours a week of active practice in order to be justified as having practice. So that is why this has occurred, and that is why this has to change. I don't actually teach. I'm the Dean of the school. I hardly do 152 hours of teaching, direct face-to-face. But why is this important? Why is general registration important? Well, you can't set foot in a hospital and stand beside a patient and instruct a student how to listen to a chest unless you've got general registration, because you would not be accreditable in that hospital. So this is an urgent issue. It's, I'm sure, easily fixed. You just need to change the recency of practice rules specifically for limited practice for teachers. And we can't afford to let this go by another year without having it fixed. So I implore you to support this motion. Thank you very much.
Thank you. Speakers for the motion to microphone 1, and those against to microphone 2. Any final words, Mark? We're going to put the vote.
I think it's a no-brainer.
Well, it's a brave statement before a vote. Those in favour? Those against? Abstentions? 3, 4, 5, 6, 7, 8, 9. The motion is carried. Thank you. That concludes the debate on the urgency motions and the formal program today. I'll hand over to the Secretary-General, who has some items for us.
Thank you, Chair. It's hard to believe that we've actually got here, and we did buy New South Wales delegation back a little bit of time for their candidate briefings, although they're going to be cutting it fine. So, a few things. Either leave your little device on your desk or hand it to one of the AMA staff on the way out. They're the people wearing the yellow lanyards. Do not take it with you. It's going to cost us money. The New South Wales candidate briefings will be taking place straight after this. It's in the QT lounge, which is up on level 15. I think all the New South Wales delegates are familiar with that venue. So if you could head up there in a moment. Two other important things. I don't know if any of the candidates are still in the room, but you all have to give me the names of your scrutineer. I have Dr. Pecораro's, thank you, but I don't have any other scrutineer names. I will need that, preferably tonight, but at the very latest in the morning, before we get into the voting process. And the last thing to let you know is that there are buses to transfer you from here to the venue. It's walkable, but certainly not at night. It's far too dark to see where you're going. And the bus transfers will start at 6:45. They're going from Edinburgh Avenue, so the front of the hotel is London Circuit. The Edinburgh Hotel is the side of the hotel. So not out the front, but on the side. That's Edinburgh Avenue, and that's where the buses will be taking you from 6:45. So those of you who are coming to dinner, I look forward to seeing you there, and thank you all for your contributions today. It's been absolutely fascinating, and the quality of debate has been outstanding, so thank you.